Good morning, everyone. So we're back after our brief coffee break. It's my honor and privilege to welcome the next speaker, Dr. Jonathon Noël. Dr. Jonathon Noël is a UE medical graduate who, following completion of his internship in Barbados and Trinidad, and as a clinical tutor in anatomy at St. George's University, moved to the UK. There, he completed his core surgical training, specialist registrar training in urology, culminating in his fellowship of the Royal College of Surgeons in Urology at Lister Hospital in Hertfordshire. He then traveled to Florida for a 2-year fellowship at the Global Robotic Institute. Jonathon returned to the UK in 2022 to take up the position of consultant urological surgeon at Guy's and St. Thomas's NHS Foundation Trust, one of the top 10 worldwide centers for urology. He is a champion for rapid diagnostic and minimal invasive pathways for general urological conditions, and his subspecialty focuses on the management of prostate, both benign and cancerous conditions. He is proficient in utilizing endoscopic and robotic technology to deliver surgery and trains senior registrars and early year consultants in international radical prostatectomy fellowship. He has an extensive research portfolio and regularly undertakes community engagement for education on cancer screening and urology management. Jonathon has strong ties to the Grenadian medical fraternity through his medical father, uncles, and grandfather. The title for Dr. Noël's presentation is Surgical Technology and Adaptation in Small Island Developing States. Dr. Noël, the floor is yours.
Thanks for that introduction, Trevor, and thanks for the invitation, St. George's University, and thanks for having me rejoin a country that means a lot to me. Obviously, as Dr. Noël alluded to, we have a lot of family here in the medical fraternity, and they all continue to inspire me and the work that I do. I'm just going to take you through a whistle-stop tour, which no doubt has its own inherent challenges. And I'm trying to move the slide around. Great. So that's me. I work at Guy's and Tommy's for the past almost going to be 4 years next week. It's really flown by. And through my work there, I've been able to manage prostate cancer in a very diverse population, because Southeast London has a lot of patients, not only from England, but from West Africa and the Caribbean. It has the highest kind of mix of Black population in the whole UK, actually. And they look to us for research in genetics, which was alluded to in Dr. King's discussion, for outcome comparison between patient groups. So it's a real honor to be here, and hopefully we can find some middle ground as to where we move forward. So surgical technology and adaptation in small island developing states is my talk. And obviously you know what both of those resemble, I'm sure. The one on the left of your screen is the UE emblem. My disclosures are here. I'm a clinical trainer for an artificial intelligence platform for benign prostate conditions. It employs water jets, so my talk should be born out of that. Why is this an important day, meeting, talk? Because the cancer burden is increasing, and there's no signs of it slowing down, and there's no signs of it changing from the last 20 years that I'm aware of in terms of technology. And I really want to task us in the room to have an open discussion. I like to give talks, but I also like to be interjected with questions. So if there's anything burning, please do raise your hand. The estimates are there on the slide, but the situation is that there is limited access to advanced surgical approaches. And patients do have to travel, and we realize that this causes a lot of strain emotionally, financially, time off work, you name it. It is not easy to travel a long distance, particularly as there are certain challenges now in the world to even travel to certain countries such as the US, etc., because of visa restrictions. So that has to be obviously thought of. And I think it tasks us with an opportunity, and I don't need to try to restate what Dr. King said so well. It is an opportunity for us to grow as an OECS organization, and technology certainly is the way or the vehicle to better outcomes. We know what small island developing states are, but we must realize that it makes us somewhat vulnerable economically. The infrastructure is limited if every island is its own kingdom and we don't work together. It's only by working together and pooling resources that certain countries have been successful in their endeavor to offer treatment to all patients within their catchment, such as the Pacific Islands and the Indian Ocean. And we're about to put out a paper in the Lancet Oncology, where the Cancer Commission group has tasked all Commonwealth countries to come up with a document, and I look forward to sharing that through Dr. Noël in terms of what our recommendations are. What's surgical oncology? Well, it's my day-to-day job, but I'll just spell it out here for those who may not be aware. It is a very important arm of cancer management, such as pathology is. Surgery also, to deliver the specimen, is important. And it's usually for localized disease management when we're removing a whole gland in a radical way. We work very well with the oncologists who deliver chemotherapy and radiation treatment. I can't carry out my jobs without them, and they certainly can't carry out their jobs without me, I'd like to think, and other colleagues, because we biopsy, we deliver specimens, we remove the tumor and lymphatic drainage systems, but also with palliation or end-of-life care, sometimes we need to offer diversions, whether that's through gastrostomy feeding tubes, ileostomy tubes for bowel cancer, etc. So the challenges I've already stated, you know that. I think human resource is one of those things, but obviously technology and the equipment is another. So there's a shortage of fellowship higher trained surgeons, and I think higher trained surgeons may probably look to the bigger centers so that they can get the volume and carry out the work that they've been trained to do. So asking a higher trained surgeon to perhaps come and start a program from scratch, however noble the endeavor, is a big ask, but it is something that certainly a lot of us do think about of how it can happen, because it needs to. And I think the lack of the advanced surgical technology is born out of costs. And hopefully after this talk, you may see a little bit of glimmer of hope. And maintenance and supply chains, particularly the supply chain that's been disrupted now with the ongoing war, is something that we will have to think about in the next few months. Everybody loves flying to our lovely region for holidays, and the reverse happens when we have to perhaps seek advanced healthcare. Because in a way, each island is isolated, patients must often travel abroad if its services are not offered. And I've already alluded to how that can really impact patients. So this is how I'm going to structure the talk from here on in. These 4 pillars, and I'll talk briefly about them, but again, anytime, just stop me and ask questions. Is that a hand being raised over there? No? Okay, all right. So developing surgical approaches. You know, I think keyhole surgery, robotic surgery, is not sci-fi, and it is something that is going to come. It's a matter of time. And what the beauty of it is that with minimal invasive surgery, particularly with robotic surgery, you get to standardize the outcomes now. And every patient, no matter which island they're from, deserves access to that. But not everybody has the ability to fly to the UK or the US or even to South America because of the cost. So how do we do this? I think Dr. King alluded to it beautifully, and I'm not going to restate the talk. In fact, I feel like he's done the talk for me, actually. Concentration of the team expertise and just being resource efficient and cutting those costs wherever possible, because robotics allows you less complications. It means your turnover from surgery to discharge is shorter. So probably 24-hour stay. We usually send patients home the same day after radical prostatectomy. We alluded to in a previous talk about centralization, or a hub and spoke model. And I was so glad to see that slide. It really warmed my heart to see that they're thinking about this, because this is the way it has to happen. A specialist center in each island specialized in particular fields, so that every island has a sense of pride in delivering something as well. Because the worry about putting all the concentration in Jamaica or Trinidad is that you start to de-skill the other islands, and then they start to lose engagement. And we're actually seeing that in the UK. In the UK, there's a hub and spoke model, and the smaller hospitals, certainly, they get a bit disillusioned. So you have to be very careful. And from the upfront, I think centralization needs to happen, despite very learned colleagues in Trinidad. Professor Narang Singh is an expert in his field of vascular surgery, and I hold his opinion in very high regard. But I do think that centralization needs to be rethought of. This was published in 2008. Low volume hospitals may produce better outcomes is something that I question. Now in 2024, very good surgeon, Dr. Wesley Francis, I think out of the Bahamas, if I'm not mistaken, coined the term high quality hospitals rather than high volume. Well, certainly I think volume gives you experience and experience gives you quality. So I'm not sure how you can unmarry the two. And it's probably a push because of the situation they find themselves in, rather than a situation that they can aspire to. So from that conclusion, volume alone should not be used as a marker, they've said. High volume centers need to be replaced with high quality centers. I'd respectfully challenge that. And I think that we need to concentrate and have a center who does high volume surgery of one particular specialty or field, and let that be the reference point. And I like the idea of universal health coverage, because you cannot exclude patients from all the other islands. They have to have access to it. This is a great document. If you want to look it up online, I implore you to take a picture. I'll share the slide. So NIHR looked at centralization of specialist cancer surgery services, and it can inform perhaps the Caribbean Cancer Portal as they come up with their document, because it looks at the findings and where things can be improved. And it talks about the outcomes of fewer surgeons performing high volume operations being better for patients. And obviously there is lower complication and death rate, which is obviously favored by patients over how long they have to go into an inter-Caribbean flight and wait at the airport. I think they would take that wait if it meant they're getting a better outcome. But but this is just the data here in the UK. So it's something we can look at, and perhaps a very interesting project for any budding students in the room who want to look at quality control about how patients view centralization of surgery. But there are challenges, Manchester certainly faced clinician disengagement by centralization. So like I said before, we have to make sure everyone is going with us. So what is robotic surgery? Those are the three main items at the top of the screen. That's me putting in the ports, and then we attach the robot to it. When the robot gets going, it looks like that. There's a big footprint in the room, so you need an actual operating space that can accommodate that footprint. And it's not a very big operating space that you need, but it certainly can be done. And that's me at the control, and then it just translates the movements inside the patient. There's nothing sci-fi about it. I don't walk away and have a cup of coffee and come back. I have complete control of the system. So I will speak more about surgical technology at another meeting tomorrow, but let's talk about low-cost equipment. I think surgical vendors and sharing of procurement is so key. We have to share our contacts and not keep them close by, because my colleague, who is a urologist in Antigua, may benefit from a low cost item while they perform the diagnosis of other patients. You can't think of yourself in silos. So I think a structured process of acquiring these goods and services, particularly medical equipment, but also procurement being looked at in terms of construction of new buildings, electronic health records. I think if we are going to transition to electronic health records, I would really implore that people do this thinking that we are all unified as one. I can't have a patient from another island come to me to another island. I have no access to their records. It's risky. Reusable and disposable instruments are important. So I think disposable is probably lower cost, but obviously you got to worry about the environmental impact and obviously climate change, etc. You want to make sure you're not developing piles of plastic waste. So I prefer reusables, but it is a cost element. So it's something to think about. And then the emerging markets of China are certainly being heavy in terms of their association with certain Caribbean islands, and it's something to perhaps consider. Portable surgical devices, I think that's important. Inter-island service provisions should be thought of. I think the portable units that I see now, people are having ultrasounds attached to their smartphone. Instead of charging it, you're putting the probe on it. I mean, that's amazing. You can go to the rural areas of the island, you can go to another island and go through security to the airport, and you're doing scans, you're guiding biopsies, you're performing diagnoses. I think that alone probably just says we need to really look at how advanced technology is and how it can be compact and used. This is a project from Royal Marsden Hospital where they looked at a manned van. They put a van out into the community. They actually tried to engage to find more prostate cancer. And what they found on the left of the screen is lots of hypertension as well, diabetes, early pickup, obesity, alcohol excess referrals. So, a man van or woman van, okay, not to be gender biased, but it really, we've got to go out to the community and find the patients. And sometimes that's a good thing. And, I wouldn't put prostate on the side because it might turn away some gentlemen. Sure, I understand that. But I think it's about education, and it's a discussion around the other things that you need to screen for as well. And sometimes on the van, all you're doing is a blood test and a blood pressure check and a blood sugar check. But what you could pick up might actually surprise you. Again, a very good project to consider. I'm going to close off now with the last section, which is telemedicine. I think technology can help small island developing states when we actually adopt technology that allows us to speak to each other. You can take a WhatsApp photo and you can send it to a friend in the UK or Canada or the US. But I think having a formalized link, it perhaps is a good investment to have, because you can speak to colleagues, they can dial in, offer guidance, they can speak to perhaps new surgeons who are doing new procedures and just need an expert to dial in once that expert has come on the ground and actually made some changes and then leaves, because that's quite interesting. We see lots of specialists come in, they do their wonderful surgery and they leave, and it's never done until they come back a year later. And I just think that's not sustainable. We have to have a link where the learning continues. And this is surgery, but it can be applied to medicine, obstetrics, gynecology, pediatrics. This is wide arching. And I really believe in telemedicine. I think it's evolving a digital operating room. You can record, you can review your work, and you can actually record your hands as they move, because for me, surgery, like medicine, is an art. And the way you actually move your wrists and your arms allow you to operate for many, many more years than someone who does laparoscopic surgery and gets a stiff neck. I think it's important. We want our medical team to be operating hopefully till they're 65. And last but not least, this is the last slide. It's a bit sci-fi, but bear with me. So there's this new thing called telesurgery, which I'll speak about more tomorrow, where they're actually doing operations from long distance. Now, you may say, well, what are the ethics behind that? But they've been doing it in China for about 5 years now. And over the last year, it's exploded in Europe and South America. And what they're doing is they're allowing you to operate, and patients are in another hospital in the same country, or if they really dare, another country. I have my own personal views, and perhaps I'll share that with you after the talk. But I certainly think it's a space that lends itself nicely to all of the separated islands one day in the future, maybe. But I have my concerns initially. But there are benefits to telesurgery. I think there are benefits to it. I don't think it's about sci-fi and stuff like that. I think they're trying to export their services without having to fly 8-10 hours every 2 months or 3 months. because we're a global population. We only really, thrive when we all thrive together. And I think it allows improved accessibility. And I'll just end with that quote. He's a Lebanese writer. You may not have read his book, The Prophet, which is one of the bestsellers. And I think it's incumbent on all of us to keep sharing, keep dreaming, and keep improving services. And I'll end there. Thank you.
Right. So thank you for such a wonderful presentation, Dr. Noel. And also thank you for accepting to present at this feature presentation segment. So the idea here is to kind of stay on the theme of the conference, which is medical travel and equity, and you did just that as a wonderful job. I will now invite the persons in attendance, both in the room and online, to take questions for about 5 to 8 minutes. So the floor is, do we have in the room? No, in the line? Okay. So I think we have time for 2 or 3 questions for this segment, well, for this presentation. Go down. Okay. So the question reads, telesurgery has been beneficial for remote regions in South America, given access to indigenous people who are unable to access care in certain regions. Is that the, and you can speak to that maybe?
It's a comment. Yep,
Uh,
I agree. Yeah, it is. That's what it's used for, to access all people.
Right. So is there any questions in the room? If not, I have my own question. I can go in. Oh, the hands. Okay, because I'm seeing Rafael Garcia. Okay, so Rafael Garcia raised his hand. So
Hi,
Good
Naomi.
morning.
Hi.
I'd just like to ask a question. In terms of persons who are probably afraid of technology in terms of robots and so, what approach is used to kind of help bridge the gap for persons who might be scheduled for surgery using robots?
That's a great question, Naomi. Thanks for asking that.
You're welcome.
I think it begins, from the diagnosis stage, from the screening stage. You need to really educate the population about what robotics is, because there'll be lots of hesitancy. It's new to this region in particular. And I think we take it for granted, perhaps in countries like Canada, the UK, US, where it's been the standard of care for 20 years. People know about it. But certainly they had the same reservations that I think people from the Caribbean will have once it's introduced. And the way around it for me is, people use a lot of social media now. You flood social media about information regarding robotics, etc., what it entails, how the room is set up, reassuring that the surgeon is always there with you. So yeah, that's a long-winded answer to say education and awareness. And I'm happy to help with that if you want to talk offline.
Thank you.
So, okay, so we can take another question. I don't know if there's another one in the chat. If Rafael Garcia still wants to if anyone has one, I can have a question myself.
Yes.
So you spoke all about centralization of surgery, Dr. Noel, and I feel that this makes perfect sense conceptually. Now, we don't have our good friend, Dr. James Hospitalis, in the room to speak to this, but we know that we're in a geographic area, very much vulnerable to hurricanes, and in the Pacific and in the ocean, there's cyclones and whatnot. If we were to set up a prostate specialty somewhere in, let's say, Grenada, so we're doing robotic surgeries here and that's our specialized care, if there is a hurricane, God forbid, that were to pass and interrupt that service, how do we anticipate for that in this model, the centralization model that we're thinking of?
Yeah, I would have conversations with our Ministry of Environments and Disaster Readiness about what they would do for high value or expensive equipment that's not even medical or surgical. What's their process. I'm sure there's a standard operating procedure for that already. We don't have to reinvent the wheel, but just off the cuff, because you've asked me, I would say probably there should be some secure basement area within all hospitals, and the robot can be wheelied down there. Certainly we had to wheel it around during COVID in the UK when we went from the infected sites to perhaps the green sites, which were kind of COVID free. You can move these machines around. And yes, after a hurricane, it takes time to build up again. So you're right, that may stall the program. So I think where the hub is set up is very important. You know, are they in the hurricane belt and being hit very often, etc.? You must think about that. But I think it's something that requires lots more people in the room to make a final decision. But that's just my off-the-cuff remarks. I don't know whether you had any thoughts on that.
I mean, it's definitely with further discussion. I wish Dr. Hospitalis was here this morning to enlighten us. But it's a good idea, I think, to anticipate for these things because we have our own regional specificities. Yeah. Anyone else before we go to another speaker? Okay. So thank you very much, Dr. Noël.
Pleasure.